I'm not sure if you have encountered in your clinics recently, after the whole Dengue brouhaha, patients who refuse to get vaccinated, even HIV patients, they refuse to get vaccinated. I've had patients with animal bites who refuse to get rabies vaccine because they say it's from the OH. So there is that kind of thinking right now because of the Dengue event. I want to share with you, this is not just in the private sector, but also in the government sector. When you talk to barangay health workers in the communities, in the grassroots level, expanded program of immunization program managers in the regions and in the cities or provinces, they will tell you that ever since the Dengue controversy happened, they have not been meeting their targets, their immunization targets. Even their targets for mass drug administration, for let's say schistosomiasis, for prophylaxis, which is also part of the DOH program. Those types of DOH programs that require administering vaccines or drugs to the people are they're being met with resistance in the field. The thing is, we don't really have enough data. Sure, they have program data at the DOH, but I've come across a set of data that's very interesting. In 2015, the London School of Hygiene and Tropical Medicine had a vaccine confidence project, and they have what they call the Vaccine Confidence Index. And they ran this survey in several countries. Fortunately, the Philippines was one of those countries in 2015. During that time, they measured overall vaccine confidence, where they measured the belief of the people that vaccines are important. In 2015, that confidence was at 93%. It was very high. After they sampled 1,000 people in 2015. So after the Dengue controversy, the same group ran the survey again. This time they sampled 1,500 Filipinos, right? And in 2018, that 93%, in terms of overall vaccine confidence, where people recognize that vaccines are important, fell down to 32%. That's in 2018. For vaccine safety perception, in 2015, it was 82%. And in 2018, it's 21%. For confidence in effectiveness of vaccines, in 2015, it was a high 82%. In 2018, it was 22%. And the last question is if vaccination is compatible with their religious beliefs. And this is very interesting. In 2015, it was 63%. And in 2018, it was 21%. So you can just see so this is the Vaccine Confidence Index. We're just lucky that, we were surveyed in 2015, so we have the baseline data. And now the 20s, the figures in the 20s are the 2018 data for the country. So moving forward, and that's the take-off point of this whole panel discussion. With the dropping in confidence and trust in not just vaccines in particular, but DOH programs in general, right? That is the type of issues that we're trying to deal with in the community level. So that's the jump-off point of this very interesting panel discussion, and we hope that you will participate later, so we will be able to engage our expert panelists in the discussion on this. So may I call on Dr. Rona Bergantin to introduce our esteemed panelists.
Thank you, Dr. Roa. So for this morning, we are privileged to have 4 distinguished individuals to join us for the scientific and public health challenges of vaccine implementation, case study, the way forward after the dengue vaccine rumble. So may I call on stage Dr. Mediadora Saniel. Dr. Mediadora Saniel is the chairman of the board, UP Medical Foundation Incorporated, a member of the Governing Council of the PCHRD, chair of the Infectious Disease Practice and Innovations at the Medical City, and is the head of the Dengue Vaccine National Expert Panel. She also chairs the National Antibiotic Guidelines Committee and is a retired professor of the UP College of Medicine. And most importantly, she is a past president and advisor the Philippine Society for Microbiology and Infectious Diseases. And then our next speaker, or next among the speakers, will be a professor and the dean, University of the Philippines School of Economics. So he has extensive experience in the collection and analysis of health data, including the US NIH Quality Improvement Demonstration Studies, or KIDS, a randomized experiment assessing the effect of health reforms on child health, which was produced over 20 scientific publications. He also served as advisor to several secretaries of health and has contributed to the formulation of the National Health Insurance Act and other landmark policies on healthcare financing, expenditure, management, maternal and child health, TB control, and family planning. Dr. Orville Jose C. Solon obtained his PhD in economics from UP and did postdoctoral studies at Harvard University as a Takemi Fellow. So let us all welcome Dr. Orville Jose C. Solon. Our next speaker modestly gave a minimal amount of data in her CV, but nevertheless, she is a member of the editorial board of advisors, Philippine Journal of Pathology, and is a member editorial board of advisors, Journal of the ASEAN Federation of Endocrine Societies, and also the National Health Ethics Committee chair. That's the most important thing, chair. So let us all welcome Dr. Marita V. Tolentino Reyes. And later this morning, hopefully we will be able to be joined by our Undersecretary of Health, Dr. Rolando Enrique Domingo. So for our first speaker, may I call on now Dr. Mediadora Saniel.
I'm Medi Saniel. I'm a clinician. I've never been involved in any mass vaccination programs. In fact, not even small vaccination programs. Siguro the last time I was involved in immunizing groups of people was, as a sorority member, you have this project. But I remember that in 1979, when I was in the late 70s, when I was a fellow in infectious diseases, and there was a swine flu raging in the US at that time, and there was that fear that it would be like the pandemic swine flu in 1918, and the US at that time decided to go ahead and vaccinate for swine flu, and of course, we all know now that that was a disaster. We had a number of cases of Guillain-Barré syndrome occurring associated with the vaccine, and I know I vaccinated scores of people when I was a fellow. So that ages me. Okay, for my topic, I'm going to try to talk regarding the science perspective of this challenges of mass vaccination. And start with this book. I think some of you are familiar with this book. We are no judge or jury here, no? We're not accusing anyone. But I think this is relevant. There is a book that recently came out called Unintended Consequences, The Folly of Uncritical Thinking. And this basically includes 10 case studies, very, very interesting, of local public policies and programs, none about health. And they illustrate how well-intentioned public policies and programs lead to outcomes that disadvantage precisely the people, especially the vulnerable, that you would like to protect, that you would like to have the benefit of the program. Okay, so the science of the vaccine of Dengue, very good trials, very rigorous, very well executed in several countries. The phase 1 and 2 trials were done in both endemic and non-endemic countries. And in the phase 3 trials were all done in endemic countries, as you have here, involving more than 30,000 volunteers from ages 2 to 14 in Asia and 9 to 16 in Latin America. Okay, and this is the famous slide from Sanofi. Oh, I would just like to review this because this is the very convincing data that Sanofi showed and presented the Department of Health, which convinced the Department of Health to go ahead with the mass vaccination. So in this study population, in the age group 9 years and up, there was a 65% reduction in symptomatic dengue cases and a 93% reduction in cases of severe dengue, as well as an 80.8% reduction in hospitalization due to severe dengue. And in the same age group, among seropositives versus seronegatives, because at that time, less than 20% of the trial participants had blood taken prior to the immunization. But it was seen that there was a difference in terms of the efficacy of the vaccine, with 82% in seropositives and 52% in seronegatives. There was also the risk of hospitalized dengue in 2 to 5 years of age during the first year of the long-term follow-up, with a relative risk of 7.45 among the vaccinated versus the non-vaccinated group. As a result of these studies, WHO came out with a paper in July 2016, and the position paper states that countries should consider introduction of the vaccine only in geographic settings with high disease burden. And as a result of mathematical modelings, they came up with 70% seroprevalence as the optimal cutoff point, above which there should be maximum impact as well as maximum cost effectiveness when you do mass immunization. 50 to 70% seroprevalence would be acceptable, but the impact would be lower. Not recommended for children 2 to 5 years of age, as previously stated. And WHO was always very careful about saying that the vaccine should be introduced as part of an intensive control strategy to include vector control, clinical care, best practices, surveillance, including pharmacovigilance, communication strategies. Okay. Remember that this came out in July, but in the Philippines, we had our vaccination earlier in April. And Sanofi came out with this very nice release announcing the announcement of the Department of Health Secretary to go ahead with the vaccine. ahead of the WHO position statement. There were theoretical concerns about the safety of the vaccine, and I will not go over each of the theoretical concerns, but there were some concerns that the vaccine might put at risk of developing a severe form of dengue, some of the children, especially those that were seronegative. And there were a number of concerns coming from Dr. Halstead, so both international as well as local experts. And they made sure that these were communicated to the health authorities. However, this was not really heeded, and the rest is history. So we had the vaccine, and there have been problems with the vaccine. And why did that happen? What did the data show? There was an additional analysis of data showing the efficacy as well as safety of the vaccine among a subgroup of the participants that had serum taken at 13th month after vaccination, which inferred the serostatus of that individual prior to vaccination. So this was additional data that came out in November. And I got this from the background slides that was presented to WHO SAGE this year prior to WHO coming out with a statement. And it is here, it's very clear that as far as efficacy is concerned, there is indeed protection. There is indeed efficacious vaccine at different age groups when you have seropositive individuals. That's all very clear. You all have the lines above 1. However, I'm sorry, I'm having problems. Okay. However, among seronegative participants, the efficacy was not as impressive. And in fact, the efficacy was no longer significant. In terms of safety, and this is risk of hospitalized as well as severe dengue. Note that among the seropositives, we have protection from hospitalization as well as severe dengue. You have the numbers to the left of your forest plot. But among the seronegatives, you have numbers that are to the right. Okay, so these are additional data that were shown. As a result of this, Sanofi came out with a statement in November changing its recommendation, and WHO subsequently came out with this position paper. And the most plausible hypothesis that is stated by most experts is that the vaccination among those who are seronegative acts like a primary infection, so that the secondary infection, the first infection coming right after vaccination, which is the second bar, turns out to have to be a severe infection. Okay, so this seems like the most plausible explanation. There could be other explanations. We really don't know, but that is the most plausible that is being discussed. Okay, so this is the Sanofi change in their press release, and WHO had to make a formal statement and came up with these recommendations as of this year. Okay, the WHO did acknowledge the public health role of the vaccine and its protective benefit, but was very cognizant of the harm more than the benefit among seronegative children, even those in the 9 to 16-year age group. So upon deliberation and a lot of meetings and review of all the data, this is the preferred approach of WHO, the one on the left. pre-vaccination screening. Hirap gawin nun, ano? Pre-vaccination screening with a serologic screening test. Unfortunately, there is no optimal serologic screening test. The dengue IgG ELISA would potentially be the best one that we have, but how many hospitals have it? We have it at RITM, but most of the other hospitals do not have IgG ELISA. No, it is not a point of care test. What we have in a hospital, in our hospitals, are the rapid diagnostic tests, which are more point of care tests. But even these tests are not really optimal in terms of accuracy. So in terms of sensitivity and specificity, they're not really that high. Okay, but that would then be problematic if you do pre-vaccination screening before you vaccinate on a mass scale with a test that is not optimal, which is not point of care test. You will have to ask the participant, the child, to come back. So it's very, very problematic. But this is the ideal and the preferred safe approach. Okay. What is the alternative approach? The alternative approach is equally as bad. It's even more problematic. You have to have data that through population surveys can identify the areas with high seroprevalence. And as you very well know, the data for the Philippines are really quite limited. We had very good data from San Pablo, the areas where the trials were done, and in Cebu. But for the rest, we really do not have very good data regarding seroprevalence. So it is recommended that before you do your mass vaccination, you should know what the population seroprevalence is. And ideally, it should be at least 80% before we can say that, yes, mass vaccination would work and that the benefit would be less harmful. So this is the vaccine dilemma that the rest of us, the rest of the speakers will try to answer, weighing the benefits for many against the risks for a few. And the question for us, and in the subsequent discussion, I don't know if you can really answer it, after the disastrous experience, is implementing a dengue vaccination program really worth it? Is it really worth it? I really salute all those who are involved in mass vaccination programs. Kasi ang hirap pala, no? This is the WHO Manual, Principles and Considerations for Adding a Vaccine to a National Immunization Program. And if you're able to do this, saludo ako talaga, but it's got to be done. If you're gonna introduce a new vaccine, that's how it should be. And the key issues, according to the WHO, to consider when deciding on the introduction of a vaccine is not just the disease, and not just the vaccines, but everything else, including the strength of the immunization program and the health system. And I will not go over the principles, pero ang daming kailangan, no? If you're in charge of a program, especially introducing a new vaccine, there's a lot of thinking involved, and there's a lot of science to it. Strong country-led evidence-based decision-making, well-performing program with well-trained task health force, education and communication, very important, cold storage, logistics, safe immunization, monitoring, evaluation, including pharmacovigilance, accountability, so on and so forth and so forth. So talaga nakakatakot. And was this done? When we introduced the new vaccine, was there a command post? Talaga mga bang we were all very conscious that this had to be done, and we were accountable. As I said, I've never run a mass immunization program, and I probably will not volunteer at maraming kailangan gawin. No? And once you do have the vaccine, from vaccine licensure, you have efficacy and safety, ginawa ng Sanofi yun. We should not forget the third arm in the triad. There is a lot of implementation, research, assessments that needs to be done. And Dr. O'Brien, who is a member of SAGE, who is one of those who is overlooking malaria vaccines. The malaria vaccines have already undergone phase 3 trials. But instead of going ahead with mass immunizations in Africa, they're doing implementation in phases, research in various parts of Africa before going into mass immunization. And I think we should take cognizance of this statement from the experts. Failure to tackle the implementation phase with the same commitment shown to the licensure phase will pose greatest risk for vaccines developed mainly for the world's poorest poor. So, let's go back to my first slide. I will end with this. Unintended consequences. As I said, there were 10 case studies that were beautifully presented. None on health. Dapat siguro merong sequel. And it should discuss 10 case studies on health programs. But they conclude that attempts to introduce new programs or undo existing ones are often driven by short-term considerations, carelessly overlook the effects of such actions on people's motivations and behaviors, or conveniently ignore valuable information. Overestimating the administrative capacity of the bureaucracy is also a common cause of ill-conceived and poorly designed programs that prove counterproductive. And lack of evidence-based critical thinking contributes significantly to the adoption or advocacy of policies and programs that have or would have led to adverse consequences. Thank you very much.
Okay, so just to contextualize, the expanded program of immunization of the Department of Health has been in place since 1976. And since that time, so the basic structure has been there since that time. Since then, the Department of Health would add more and more vaccines into their program, right? To make sure that children and also mothers get the necessary vaccinations. The beauty about hindsight is it's always 2020. And that is where, we will be coming from. Because really, moving forward, it's what we do because of this experience, right, that will really matter, right? And of course, learning from this experience. So if you remember, Dr. Saniel had one slide about safety. Do we risk the few for the safety or benefit of many? And I think there's no other better person to discuss that than our ethicist, Dr. Marita Reyes.
Thank you, Kat. Maybe I'm very honored to be referred to as ethicist, but I am not. I'm just interested maybe in ethics, but I do not think that I have had any really formal training in ethics, no? So what I'm going to talk about would be the ethical, how do we look at the ethics of mass vaccine implementation. Ito ba yan? Okay. Doon. Okay. The first three slides, I just want to put in context what we presently know about health and ethics. And we are very familiar with healthcare ethics. Most of us who have had training in medicine, in nursing, in medical technology, in pharmacy would be very familiar with the professional ethics of practice and of any form of healthcare. We know that. There's something that's echoing. I can hear it. Does it bother you? We also are familiar with health research ethics. Since the early 2000s, we have been developing a whole system of health. There's something echoing, no? Health research ethics, including clinical trials. So yon maliwanag sa atin. But how about public health ethics and public health research ethics? We're still grappling with, do we differentiate public health practice from public health research ethics in the same way that we differentiate the ethics of medical practice and the ethics of clinical or health research? I went too fast. Okay, similarities. Well, there are similarities. For example, they all involve human beings. And that's why there is ethical concern, because of the involvement of human beings. And also, you'll be happy to know that the same universal principles can be applied to all, to medical practice, health research practice, to public health, ethics, and all that, no? So if you remember respect for persons, about respecting their autonomy, and we demonstrate that through the informed consent process. We talk about the principle of beneficence when we balance benefits and harms and see to it that there are more benefits than harms. And if there are more harms, we do not do it. The principle of non-maleficence mandates us to be able to identify the risks. And if there are risks, that we put in place mechanisms to mitigate these risks. And the principle of justice refers to equity, the sharing of burdens and risks, and in our selection of participants. So all of these principles are also applied to all of our concerns: medical practice, medical clinical research, public health ethics practice ethics, and public health research. But there are differences. For example, the objective of research, of course, will be different from the objective of practice. And the units of interest will be different in practice in health. If you do health care practice, then you are dealing with individuals. Your unit of interest would be individuals. And when you're doing public health, either practice or research, you'll be dealing with communities or populations. The moral agents also involved in medical or healthcare and public health would be different. On one hand, you have practitioners and researchers, and on the other, you have organizations like the Department of Health or agencies. The system of ethical review is also different, because in ethics of healthcare, you have professional organizations and you have institutions, like hospital ethics committees, that will look into this. No? For health research ethics, we have now a national system for health research ethics review. But this is not yet true for public health, neither for public health practice nor for public health research. they will also differ in the application of the ethical principles that I just enumerated. Now, in trying to prepare for this presentation, I came across an article by Dr. David Isaacs from the Department of Infectious Diseases in New South Wales. And it's like the title that I would put if that's his title. And sabi ko, swak na swak ito sa aking presentation. An ethical framework for public health immunization programs. So I read through it, and well, we probably will differ in our presentation because he presented 7 ethical principles in immunization programs. But I thought I'll stick to the 4 that we know and try to fit in. So medyo iba yung framing. But I learned a lot from his examples. So many of my examples I derived from this article, and I recommend that you also read it. Okay. Now, let us look at public health programs, how public health programs will look at the principle of beneficence. Well, of course, we are all aware of the benefits of immunization in the prevention of disease. And that's also a public perception, that if you do immunization, you will prevent disease. So when we communicate with the public and talk about immunization, ganun pala, I have to hold it farther. And you talk about immunization, and it's not always preventing disease, but maybe preventing a more severe form of the disease, then that has to be explained because the expectation is different. All right? So we also benefit from immunization when we talk about herd immunity. And here there is reduction of disease transmission. I don't know if this has been established in dengue, whether dengue immunization would also confer herd immunity. But overall, there should be a reduction or prevention of societal cost of medical care because you are preventing disease or you are preventing the more severe form of the disease, and therefore there will be less societal cost. But very clearly, the benefits from the program should always be better than those achieved from alternative options. Ang example na binigay ni Dr. Isaacs was that of pneumococcal vaccine, giving pneumococcal vaccine because of smoking, to prevent pneumonia among smokers. And he said that, well, if you compute the cost effectiveness, then it will be better if they just stop smoking. If the program would just be do not smoke. Okay. How about the principle of non-maleficence? The interpretation of the principle of non-maleficence would be in mitigation of risks of adverse events. And therefore, it is mandated that we should always implement a post-marketing surveillance as far as vaccines are concerned in order to prepare the system, the agency, for a timely response whenever adverse events are identified. Of course, we are all aware that the phase 3 trial won't be able to give us all the possible adverse events that can happen, and this can only be identified during a post-marketing surveillance. And here I put a little note here that Dr. Isaac says there always be changes in individual risk in the process of doing a mass immunization. How about the principle of justice? I noted that the principle of justice is a little more complicated in public health programs. Because it says here, there is an ethical obligation of public health authorities to ensure that any community immunization program is likely to be as cost-effective as other competing health interventions. As you can see, this is a zero-sum game. If you put money here, you'll have less money here. And therefore, you have to be sure that the competing health interventions doesn't suffer that much. No? Then there's the principle of equity. And here I would like to point out the advantage of mass immunization is really it lessens inequities because you are providing immunization to those who may not have access to health care. No? Okay. So, but especially, you should have programs for the vulnerable, like children, like the elderly, like the poor, the disadvantaged sectors of the population with higher disease incidence. Now, this is interesting, the principle of reciprocity, especially when there is the herd immunization, when there is herd advantage, no? It is a no-fault compensation for vaccine injuries. Because here it's saying that those who allowed themselves to be immunized, that's part, they are offering themselves, they are taking on the risks so that the community will be better off. So when they suffer vaccine injuries, then the agency should consider a no-fault compensation. Okay. Now, the last principle is the principle of respect for persons. And you must take note, in the other ethics, the medical care ethics, healthcare ethics, health research ethics, we always put the principle of respect for persons as the first. Here, I noticed that it was put last. Why? All right, here there is a balancing between individual autonomy and community interest, no? But still, respect for persons is still involved, respect for their autonomy, and therefore immunization must be voluntary. And if we must implement informed consent, then the information must be enough to make them decide whether to participate or not. We must avoid coercive measures, no? But the second one is very special for public health immunization or public health programs, because the second, promotion of public trust, is a recognition of respect for communities. That we respect them because we want their trust, or we want them to trust us because we respect them, no? And this means better public consultation that includes community values into decision making. This is very unique for public health programs, especially for mass immunization. Now, what are the ethical challenges in mass immunization? Number one is sound ethics requires sound facts. Dr. Medi just pointed out earlier that we have a bad data collection. We don't have reliable data. Did you say that? I mean, so if you are working in a system where facts are not clear, we are in trouble. because it will be ethically, it will be very difficult. The ethical challenge will be higher when your data are not there. All right. We must always, then there is the ethical challenge of, remember, mass immunization means immunizing everyone. And so we are not just benefiting one individual, but we are benefiting a population. But individuals may not always be benefited. No, because benefits, risk and benefits to individuals vary depending on age, disease incidence, and immunization levels. Notice the data on below 9 to 15, above 9, about 15, and adults being different as far as risk. And yet you're doing mass immunization, treating them as if they were all the same. One important ethical challenge here is we are involving healthy individuals. So imagine the public perception of a healthy individual, okay siya, you give a vaccine and he gets sick. Okay, that will be very difficult to explain. And the involvement of children. And the informed consent process is difficult when you do mass immunization. No? It's different from a clinical immunization when the doctor is face-to-face with a patient, having the time to inform him or her about all the possible risks and the benefits. But when you're doing mass immunization, how much information can you really provide that quickly to be understood and to make the proper decision? Now, compulsory immunization is also an ethical challenge, and it can be resorted to only when the disease is sufficiently severe and the vaccine is safe and effective. No less. Only when this disease is sufficiently severe, maybe like Ebola, no? And the vaccine is safe and effective, and without the Ebola vaccine and that's another balancing act. There is also an ethical issue when you do a compulsory immunization of health workers. All right. Now, having insufficient vaccine trial data in disease outbreaks is a horror story in ethical considerations. What do you do when there is a disease outbreak and yet there is insufficient data to support efficacy or even safety? Whoops. All right. So, here now, therefore, I recommend the following standards for public health programs to make them ethically acceptable. I'm using the word acceptable. I don't know. I wonder if this coincides with the WHO. Kasi I just gathered this. I derived this from my presentation. But I'm wondering if this coincides with the WHO. No? Number one is Department of Health must have rigorous epidemiologic data. Without a good set of epidemiologic data, wag na tayong mag-usap tungkol sa mass immunization. No? We must put in place a very diligent disease surveillance system. What did I mean by a diligent surveillance system? The people who are gathering data on surveillance system must know why they are doing this. the significance of their activity. Kung nag-gather lang sila just for the sake of filling up a form, wag na natin pag-usapan ang mass immunization. We will be in trouble. No? Number 3 is a very culturally sensitive risk communication. Paano ba tayo makikipag-usap sa ating community when we plan a mass immunization? And an effective and consistent public education system. Nakita ko yung maraming ads na pinadala ng DOH. Maganda naman sila after the Dengue, but that was after the Dengue. And the last one, I think, is what we're missing, the public consultation mechanism. And yesterday, I was attending a convention, the National Convention on Health Research Ethics, and I picked up a term that I think is nice to remember, that the Department of Health must also possess procedural virtues. Procedural virtues. And what are these procedural virtues? Whenever we do public consultation, there must be openness, there must be inclusivity, lahat ng pwedeng sumali, dapat kasali, and accountability. So, thank you very much.
So I think what a very important point in the discussion of Dr. Reyes is, hospitals have ethical review boards. Academic institutions have ethical review boards. Do public health programs have the same mechanism in place? When, more people are bound to be affected by programs of, let's say, the health department. So that is a very important question. And we're fortunate that hopefully that's one of the points that he will touch on later. He will be discussing about the actual implementation of mass vaccination programs from the point of view of the Department of Health. Dr. Domingo.
Thank you. Good morning, everybody. Good morning to my titas and my kuya. We've been working together for quite some time. Well, first of all, disclosure, I'm not a vaccine expert. I was just at the right place at the right time, or the wrong place at the wrong time when the events unfolded. So let me just share with you some objective observations on what happened and what we have now. This works like this. Okay, I think it's the wrong slide that you got. This is for April 17, 2018. Yeah, okay. Maybe Orville can go ahead. I'll just fix I have a lot of dengue vaccine slides.
Okay, so before we go to implementation, let's ask a very important question. Where do we get the money? And if there are several vaccines available, which one do we put our money on? Right? How do we make that decision? And this is the money guy, Dr. Orville Solon.
Pera muna.
MD. Actually, hindi po siya MD, PhD. But he's happy to be conferred the MD for today.
It's an honor to be given the degree by PSMID. Just to get started, take note of the way the sequence of presentations are being done. And I think the sequence also tells us one important point about mass vaccination. First, get the science right, it should be rock solid. Then we should be clear about all the possible ethical consequences when we have the vaccine. Then third, we have to figure out first what the costs and the difficulties are of implementation, and then look for the money. So I think that should be the sequence. I think part of what we lost in Dengue was that the sequence actually got mixed up. We looked for the money, and then all sorts of things, and then implemented it without ignoring the science, and here we are. Breaking the sequence led us to this very disastrous situation that we're in. This is my imaginary slide. If it were shown on the screen, my first slide would be about why would you bring an economist into the table? And there is only one and only one answer. You bring an economist on the table, or you do economic evaluation, cost-benefit analysis, or cost-effectiveness analysis, because we have limited budgets. If we had all the money in the world, we'd be able to actually finance and do everything that is worth doing. I'm going to talk about two vaccines, because these two vaccines allows us to draw very important lessons for practitioners who do cost-effectiveness analysis. And the vaccines are PCV and Dengue. And both are also they're also both politically charged, those two things. Okay, so as I mentioned, we have fixed budgets, and we want to find out what's the best use, how much health can we produce for that given money. And this question happens at three levels. First, at the level, people call it macro, but my mother at the household level usually also talks about this. This is really worrying about health versus food versus clothing, shelter, education. Those prioritizations have to be made. And notice that all these other expenditure items have health effects, right? And the second very important thing that we have to keep in mind when we do economic analysis is that most Filipinos spend between 80 to 90% of their incomes on food. So there is very little else for them to actually pay for their health care. The second level of analysis is when you decide which health conditions or disease you would prioritize. We cannot attend to all. And then the third level is when you determine which type of treatment, alternative treatments, for a given condition. So we're moving from sort of very macro sectoral questions then within the health sector, and almost like at the level of the clinic or at the treatment level. This is my first caveat. Doing cost-benefit analysis, or more familiar to you, it would be cost-effectiveness analysis, is highly nuanced, meaning there are lots of ifs and buts. And that's mainly because information is incomplete, right? Because of ethical considerations, cost, and time, we will not have all the information that we need. So what we do instead is we do a lot of simulations, sensitivity analysis. So for example, we pick data on effectiveness from one country, and then we say, so what would it be in the Philippines? So we say high, middle, low, or we do different rates. That is quite a bit of, well, that's really fudging the data. But we have to fudge because we don't know the actual data that applies to us. And we do that for cost as well. We use many assumptions. when we change costs items or effectiveness items, our results change. And when budgets go up or down by certain levels and prices, also in other words, if you want the Secretary of Health to actually make good judgment calls, because in the end, they will be judgment calls. Their political decisions will not be based on hard science. But good judgment calls, we can help them do good judgment calls if all the simulations and all the possibilities are presented to them. I mean, the Secretary of Health can decide one way, but then your obligation is to tell him or her that there are other approaches as well. Okay. This is an example of cost effectiveness analysis that was done for PCV, which led to one big political change as well in circa 2015. Okay. Actually, this is a summary of very long tables. I'm picking this out from a WHO report way back in 2013. So what you have is at the rightmost columns, you would have PCV compared to not doing anything, and then PCV 13 doing not anything. The numbers there refer to what it would take in terms of cost to generate a year of life saved, either measured in terms of QALYs or DALYs. In other words, if we were to produce one good, healthy year, this is what it will cost to produce that. So it's notice medyo mahal, no? $2,000. Kasi yung nature ng disease na piniprevent, hindi siya masyadong killer. Right? Okay. Now, the point of all this is that dalawang simulation ang kailangan. Take note of two things that are moving. First thing that's moving in the top panel are the prices. So tingnan mo sa ibabaw, you would have PCV10 at $1,540. Down below, it's $1,385. So in effect, there was a scenario while the analysis was doing that the prices changed. So the analysts had to go back to the drawing board and actually calculate again the entire set of simulations with new prices in there. The other thing that you should watch out for is coverage. All right? First, coverage meaning cover everybody eligible, then cover 700,000 lang, and then the third case, which was an add-on, was that the DOH said we only have about $20 million to spare. And that would buy us coverage of about 500,000. Notice that as the coverage declines, PCV10 actually looks better. That's what we're saying. And now you have a situation where the Secretary of Health actually has a dilemma because at certain assumptions, PCV13 looks very attractive, worthwhile doing, and given severe budgets, maybe it's PCV10, not 13. Here's when judgment calls happen, right? But notice that for those judgment calls to be made correctly, all the simulations would have to be presented to him or her. And the ethics of research requires that we become honest brokers of analysis, meaning everything that's possible, feasible, we present that clearly to the Secretary of Health. We don't prejudge, the danger there is the analyst actually makes decisions for the Secretary of Health by picking a subset of the simulations. Sorry. This is another illustration, but I'll skip that for time. The lesson from PCV10 is really about analysts being honest brokers of information and advice for the decision maker. The second lesson from this second vaccine is that, alam mo, standard economics analysis, cost benefit, cost effectiveness, do not actually take into account cost of doing harm. Why? Because the assumption there is that the science is rock solid and the ethics are properly complied with. So hindi namin pinoproblema kung if you actually lead to indirect harmful effects. But what happens is that when harm happens, first of all, people get sick, and there is a cost to that in money terms. They will have to stop working, there is suffering, there is loss in consumption. We will have to value those things. The second thing is that, of course, they will have to go and seek care appropriate for that illness that was inadvertently caused by the vaccine. And that's also going to be expensive. And thirdly, as alluded to the previous presentation, this is a very big social cost because we've lost goodwill and trust from people. And why are we saying put money into it? Because it's going to be very expensive to actually run serious campaigns to win back people's trust. Being honest now, launch information campaigns, talking to people, going to media, that's going to be expensive. But that has to be brought in. Just a few things. One is that when we estimate or include cost of doing harm, this has to be seen as compensation for our for breaking trust. This is not a benefit. This is not an extra package. This is really for recognition that we actually were culpable and this is almost like retribution. And so these are our considerations, meaning we have to provide them care and compensation at their convenience. It's not something that we will have to sort of pinch on. We did an exercise and submitted to the DOH an estimate of what we thought it would take to actually compensate for the harm done in Dengue. And our low estimate was about 1 billion pesos. And it's 1 billion pesos simply worth of healthcare services. If you include the cost of further tests, surveillance, pre-hospital care, long-term care, and so on and so forth, our estimates would run up to about 3 billion, which is almost like the cost of Dengue itself. In effect, we would end up paying double. We paid for the vaccine, and then we paid for harm. Now, moving forward, let me just wrap up by making at least these 3 points. One, analysts should be honest brokers. It should present all the facts, all the possibilities on the table, all implications and all costs. Right? Second, because we've already seen that decisions are made without considering the science and taking risk and ignoring ethics, I think we might have to actually include as part of guidelines an explicit component for the cost of harm done, which we do not at this point. It's not really part of our practice. And then thirdly, for transparency, for people to be able to validate, cost effectiveness analysis should be published. Kung hindi man journal, pwedeng put up in the web, or maybe PSMID can actually require it of its members, so that And it's not just the slides that are published. What are important, kasi ang problema doon, when you look at economics analysis reports, it's like 10 pages of text and a gazillion simulation tables. And sometimes the devil is in the simulation tables that we ignore, right? That has to be looked into. Thank you very much.
Okay, so I think Dr. Domingo already has a very long list of things that he has to take back to DOH. So, Dr. Domingo?
Yes, I promised everybody that all the messages will get there. Can we start slightly? Okay, yeah, this is the right one. Well, we all know the value of vaccines. No? Now they have increased life expectancy, protected the herd, and eradicated illness. In the Philippines, well, in 2012, the World Health Assembly did the Global Vaccine Action Plan for 2011 to 2020, and this was endorsed by 194 countries, committing equitable access to health services. This was later adopted by the Western Pacific region in 2014, incorporating the global and specific goals for the region. Of course, our goals really were to eradicate polio, eliminate measles and rubella, eliminate maternal and neonatal tetanus, and increase equitable access to life-saving vaccines. And yung goal natin really was 95% coverage in the National Immunization Program. In 2017, the global coverage remains at 85%. And there have been no significant changes in the past few years. Parang merong ceiling na hirap lagpasan na yung 85%. We could have avoided an additional 1.5 million deaths, of course, if we reached our goals. And about 1 out of 10 child globally does not receive all of their vaccines. The expanded program on immunization, which we now call the Philippine National Immunization Program, was established in 1976. First, we started with 6 vaccines for tuberculosis, polio, diphtheria, tetanus, pertussis, and measles. And today, the NIP includes 14 vaccines, which also covers for populations beyond the infancy, even older people. The dengue vaccine was introduced, if we all remember right, in April 2016, and it was abruptly discontinued in December 2017 after the manufacturer announced new findings regarding the effects of vaccine in relation to pre-vaccination serostatus and not just age. So this is the situation that we are in now. Yeah, this is the sad graph. The graph shows us the national immunization coverage from 2013 to 2018. Of course, yung 2018 natin dito is only until June, but we can't be too optimistic because we know that that really is the trend. Despite extensive efforts to promote immunization, first of all, the country barely reached 80% coverage in the past years. From 2013 to 2014 yan. Talagang ceiling natin yung 80, medyo nahihirapan tayo lumagpas doon. There appears to be a drop in immunization coverage for every vaccine from 2015 to 2017. So that drop was actually there already, even before dengue vaccine. The proportion of the fully immunized children reached 71% in 2015, it was 70% in 2016, and 67% in 2017. So we were really at a vulnerable stage. We were not hitting our targets, and the added blow made it a little more difficult for us. According to the Family Health Office of the DOH, the contributing factors to the drop in immunization rates include, vaccine stockouts. They were having problems moving the vaccines from procurement, central office to the level of the communities. Limited capacities in the local situation. There are some hard-to-reach areas, and then when we have emergency situations, very difficult to catch up with vaccinations, especially during disasters. And there was limited supervision and monitoring of the frontline health workers in the setting, of course, of a devolved health system. Pagdating sa community, wala na kasi sa kamay ng Department of Health. But the greatest plunge, definitely, I think without question, was the great drop after 2017 was definitely due to loss of confidence in vaccines after the Dengue fallout. When we recent, of course, studies, you've seen that Filipinos have decreased confidence not only when they say in vaccines, no, it has gone down to 20-30%. And the problem is, I think what we were not expecting also is that there was also decreased confidence in the public health system, in the Department of Health. Historically, the Department of Health is one of the best performing departments when it comes to public perception. Pag may SWS survey, Pulse Asia survey, ang Department of Health laging nasa taas yan with DepEd and DSWD, no? Near 90s, 89. In June of 2018, our rating was at less than 60%, no? And so when you see this graph of decreasing immunization rates, it also, there's collateral damage in every other public health program of the Department of Health. Hindi lang yung immunization natin ang nagkaroon ng problem. So this was, of course, the response of the Department of Health. We really tried our best, no? I mean, there was a lot of risk communication going on, giving accurate information. We were intensifying our monitoring and surveillance. In fact, no, there really is, no, a master list. I've seen it. It's been given to the Senate. It's been given to Congress under subpoena. And I've seen it's a 98% validated master list of about 890,000 children that we check and counter-check every time we have cases na being monitored and surveilled and seen and detected, I mean. We had our AEFI case detection, which was improved significantly. We've had people trained for it. And then the health financing assistance, no? So, like I think Orville was saying, or some other, for some other countries, no, there's usually a fund for vaccine, for vaccine-related illness. Basta nabakunahan ka because you take the risk for the whole population. If something happens, you should be compensated for it. In this case, we pay for every illness, any illness actually that a child that received Dengue gets, no? And we try to work on that. Pero medyo hirap pa din, no? We do everything, but it's not that easy. Now, in October 2018, the DOH, some LGUs, WHO, and UNICEF conducted a community-based assessment of public health perception on immunization. This was done in 346 households around Metro Manila, iba-ibang communities. There were 13 communities. Tapos ito yung nung response nila. In at least one, meaning in that community, in all 13 communities, hindi pala pointer, sorry. In all 13 communities, there are members of that community naman saying that, yeah, we do accept vaccines. But in at least 4 communities, some were saying, yeah, we accept some, but not all. In 2 communities, they were saying, we accept some, but maybe we should delay. We'll just wait a little more. No, we won't follow the schedule. We just want to get a little more information. In 2, they refused completely. No, refused. We really don't know how safe this is. We don't know what's happening, and we do not want vaccines. And 1 was just refused with no. In at least 1 community, there were people saying, refuse. We don't need to give you we don't even need to give you any reason. We just don't want. So, knowing that Filipinos like to say what they think you want to hear. So 13 might even be an optimistic number, no? Parang pag nag-party tayo, lahat naman pupunta, di ba? Pero pagdating ng party, 6 lang ang nandun. Nahihiya ang mga Pilipino magbigay ng negative answer. So I think, practically speaking, there really is a lot of mistrust, and a lot of people are willing to delay the vaccines of their children or actually refuse. And this is really the problem now. The good thing is, they say naman, they still trust us. No? They still trust the doctors. They still trust the nurses. But, I think we just have to strengthen and get that trust back. In more than half of the communities, at least 1, aired the following sentiments. Ito kaya sama ng loob ng mga workers natin. Pag pumunta daw sila sa area, ang pangit ng pakiramdam kasi naririnig, ayan na naman, papatayin nyo na naman yung mga bata. No. We forgot, at the start, we were thinking of all of the health, of the community, of the children and the families. We forgot actually about the health workers. It took us a few months to realize that the hesitancy was not just in the community, it was in the health workers. Natatakot na silang pumunta kasi sila mismo, unsure sila yung ating mga health workers natin. Nung nagkaroon daw ng issue sa Dengue, nag-lie low sila. Siyempre, medyo mahirap, no? Medyo natatakot sila. At tapos, magkakaroon pa ng barangay elections towards the end of the year. So, natakot sila lahat. Ano? Baka mahawa sila, masama sila. So, it was a real concern. So, I guess this is the lesson here. No? When we do not do the proper rollout of a national immunization program, especially for a new one, then you get loss of confidence not only in vaccines, but you get the loss of confidence in the whole health system, in the Department of Health, and other public health programs. And I guess we just mean that we just have to work a little harder next time. So this is concerns about vaccine safety can be linked to, of course, hesitancy, but safety concerns are only one factor that may drive this hesitancy. While hesitancy to accept immunization has occurred ever since vaccines were first introduced, current concerns on immunization following the dengue vaccine issue may further challenge the health workers to reach the immunization coverage targets to prevent outbreaks and reemergence of vaccine-preventable diseases. We don't know how many outbreaks are coming up right now. No? Within the immunization program and beyond, education and training of healthcare workers to empower them to address vaccine concerns and patients, families, and communities is needed. No? So we have to get the health workers on board again. We have to train them again. We have to talk to them again so that that confidence is passed on to the community. Kasi kung yung mga kasama natin, sila mismo may duda, nahihirapan talaga tayo. We have to ensure education and knowledge about vaccines in younger individuals, and that's a good opportunity to further shape the behavior towards vaccines in the future. And as a part of good immunization practice, we need to engage civil society organizations, local communities, and healthcare workers. We really need to do further studies in vaccine behavior after this issue. And I think, it's just really, it's not a regular business as usual right now at the Department of Health. So the great challenge now is, how do we move forward? We still have a lot of goals. We still have a lot of obstacles. We need to correct a lot of information. Plus, we have time constraints. We have targets to meet. And now, if it took like 2 minutes, dati siguro to convince a mother to do and to give the child immunization, our health workers now need 15 to 30 minutes to talk one by one to the families. No? So nahihirapan talaga tayo. We still have social, cultural, and political barriers. For example, the latest measles outbreaks that you've been hearing in Sarangani come from a community, from an ethnic community that has always been very, very difficult to reach. Talagang mababa yung coverage nila. Kaya ang problem ngayon, mababa na yung coverage, pati yung community surrounding them. And infection is getting to them. The herd immunity is not there. And we're now getting all of these outbreaks. Our strategies, of course, have to be multi-pronged. We have to reach the unreached. We have to reduce the number of dropouts. And this will only work really with more diligence and more patience on the part of the health workers. And we have to limit our missed opportunities. Ito pa yung next na problem natin. Since year 2000, the most countries have added 2 other vaccines recommended by WHO for universal use. That's hepatitis B and Haemophilus to their routine immunization programs. And even in the DOH, we plan to add some more. Actually, we already have vaccines, for example, for Japanese encephalitis. May JE vaccine tayo. This is a new vaccine that we are ready to roll out. But how do we introduce a new vaccine in the current setting? So the pneumococcal conjugate, for example, and the rotavirus, they are ready. And there are things that we just have to work on. First of all, there's that we really need to work on what I think on the far left, yung sinabi ni Ma'am Meti, we have to make sure that the disease is a public health priority before we introduce any new vaccine. The disease burden should be really high. And of course, other disease prevention control measures should not be as effective as that vaccine. The vaccine should have good performance and the characteristics should be there and should be well studied, and the science should be very clear. We have to, of course, settle the economic and financial issues, no, as said by Dr. Solon. And of course, the availability of the vaccine supply. And we really just have to strengthen the program right now. So this is where we are right now. And the problem really is, how do we roll out a new vaccine at this time? And it will go back to the steps that have been indicated before. We just have to diligently, slowly, and surely follow the steps recommended on how to introduce a new vaccine into the population. And I just hope that the Department of Health has learned its lesson, and that we will now do everything, and like they say, even with better hygiene, sanitation, and access to safe water, infections still spread. When people are not vaccinated, infectious diseases that have become uncommon quickly reappear. And new ones that we want to disappear will not go away. And the only way we can do it for the good of the public is by doing it properly. And I think this will be the message for the Department of Health for the next few years to come. Thank you.
Thank you, Dr. Domingo. So one of the most difficult things to do is to regain public trust especially after the most important and vulnerable members of the society, the children, are involved. Kasi diba, basta children na yan, puso yan, luha ang puso. No? And that will be really the most difficult thing to regain. Such that before we can move forward, the damage has to be fixed. Because you cannot move forward unless you fix the damage that has been done. So hopefully, DOH will do its best, not just to move forward, but to fix and to regain the public trust. And for us, the private physicians, we should also do our role in educating the patients that we see in our clinics. So we thank you very much for joining us in this early session. We hope that you learned a lot from this session, and I turn you over to Dr. Bergen.
Okay, so to close this session, may I call on Dr. Mario Panaligan and our panel of speakers together with Dr. Catherine Roa for the awarding of certificates. So the certificate of appreciation goes to Dr. Mediadora Saniel, Dr. Marita Reyes, Dr. Rolando Enrique Domingo, and the last but not the least will be for Dr. Orville Solon.
Hello, can I have your attention, please, especially the members of PSMID? Our election booth will close at 12 o'clock. And for those of you who have not cast your votes yet, please do so. Thank you. Ano nga siya? Oo. Ikailan na to? Ang ilang LPG? Good morning again. We are going to proceed to the 20th Elpidio Gamboa Memorial Lecture. Can I have the slides, please?